Hi, everyone. Thank you for joining us. I am Christine Kabosi. I'm the manager of high performance education at the Canadian Sport Institute, Ontario. Welcome to CSIO's webinar series, Podium Parenthood, Fertility and Family Planning. And today's topic is fertility preservation and exploring your options for the future. And it's brought to us by Markham Fertility Center. At CSIO, our purpose is elevating people and performance, both on and off the field of play, beyond training and holistically as people first. As athletes stay in sport longer through childbearing years, it is important that you are informed about the options around family planning. And as part of CSIO's newly launched Women's Health Initiative, CSIO is keen to welcome Markham Fertility Center as a community partner to ensure athletes have the information they need to make informed decisions. We want to thank Markham Fertility Center for their willingness and enthusiasm to go deep on the subject of fertility and family planning and share their expertise with high-performance athletes, coaches, and the sport community. This week is also Canadian Fertility Awareness Week, so we are pleased to offer this webinar to continue the needed discussion and increased awareness around fertility and fertility education. I'm very pleased and excited to welcome Dr. Marta Wise. Dr. Wise is the Quality Director and co-owner of Markham Fertility Center and co-host of My Fertility podcast. She is committed to providing all her patients with comprehensive, person-centered care. Dr. Wise is also a passionate advocate for women to empower themselves with knowledge about their own fertility and their options for family planning. Thank you so much for leading us in the webinar today, Dr. Wise, and I'm going to pass it over to you to get started.
Thank you very much for that very lovely introduction. So today's topic, fertility preservation and exploring your options for the future. And we'll get into sort of what that means in a moment here. Just a reminder that this is part 2 of the 6-part series that we have planned. A little bit about Markham Fertility Center. We are currently 5 physicians. We do need to update the photo, which we do have planned in June. We are all fellowship trained in reproductive endocrinology and infertility, so it's our subspecializations. The clinic is physician-owned and run. We offer complete fertility care. So we do inseminations like IUI, IVF. We work with people who might be requiring donor eggs, donor sperm, and gestational carriers. So we run the full gamut of fertility. We also do a lot of early pregnancy care, and we manage our patients up to about 12 weeks of pregnancy, so that full first trimester. We have 3 full-time genetic counselors on staff as well to provide support. And for all of our retrievals and procedures that are more painful, we have deep sedation with anesthesiologists as well. So all our patients are super comfy. We are currently affiliated with Dream Fertility, which is located in Oshawa, Horizon Fertility in Aurelia. We just had our grand opening last week of our new satellite clinic in Barrie Innisfil, and we're heading to Sudbury. So we're super pumped about that, and that's going to probably come to fruition in fall of 2025. We want to provide access to care, and so fertility treatments require a lot of blood work, ultrasounds, and appointments. So that's why it's very important to us to spread our wings and spread ourselves geographically so that we can see as many patients as possible and make fertility care as easy as possible. So I always have to talk about the podcast because the podcast is like my baby, along with Dr. Garcia, who's pictured there. This is our big passion project. My Fertility Podcast, we are on Spotify, Amazon, Apple Podcasts, all the places where you would typically find podcasts. We release a new episode every week. We've covered the gamut of topics in fertility, and we have a lot more things planned. In fact, we have a full episode talking to a patient of ours who did egg freezing, who froze her eggs for social reasons, and about her experiences and about, her feelings about that. And we've done another episode around egg freezing, going into the nitty-gritty logistics, the science of it as well. So if egg freezing is something that is of interest to you and you want to find out more after this talk, check out the podcast. First, we're going to talk about, why fertility preservation, why does this matter? And then we're going to get into egg freezing, embryo freezing, and then sperm freezing. The bulk of the talk is going to be about egg freezing because This certainly is the most common, I would say, of the three, and has the most important kind of nuances and things to consider. This really goes into answering the question of why. Like, why are we even talking about egg freezing? What's the big deal? When we think about fertility and when we're thinking about somebody trying to conceive, the biggest factor that's going to affect whether they're going to get pregnant naturally, meaning by intercourse, or fertility treatment. So any of the fertility treatments, IUI, IVF, whatever. The biggest factor is the age of the egg. And when I talk about the age of the egg, I'm really talking about the person who's providing the egg. The egg provider's age, the age of the egg are the same. So age when it comes to eggs is super, super important. To illustrate that, this is a graphical representation of age and fertility, age of the age of the egg provider. On the left side, the left axis is the percentage of pregnancy per month. This is with natural conception, with intercourse. On the right side is percentage of pregnancies that will miscarry. So the rate of miscarriage. And again, along the bottom is age. So to illustrate this point, let's say you are 32 years old and you have eggs. Your chance of conceiving each month is probably 22% per month. At age 32, the chance of miscarriage is probably going to be about 15%. That chance of miscarriage is not really going to vary with fertility treatment. Then, if we contrast that with somebody who is 38 years old, we see that the chance of conceiving each month is now closer to 10% per month. And then again, that chance of miscarriage is probably now closer to 25%. So the age of egg is super important. We think of fertility in people with eggs as starting to decline around age 32. Then when somebody gets into their late 30s, 37, 38, that's when we really see it sort of decline quite sharply. And then as somebody is moving into their 40s, the fertility can be quite low. Why is the age of the egg so important, right? Eggs are finite. Eggs are very unique in the human body. They don't regenerate like hair does or like skin does, for instance. So by the time a person with eggs is born, they're going to have about 1 to 2 million eggs. By the time that person hits puberty, they haven't had any periods, right? Like they're only hitting puberty here. That egg number is going to be down to 300,000 to 500,000. By the time that person's 37, you're now at 25,000 eggs. So the rate of egg decline, the rate of eggs going down is quite steep in terms of number. The other big piece of this, and arguably the more important piece, is quality of the eggs. So there's quantity and then there's quality, right? So now we've talked a lot about number. If you think about it, if you're 37 years old with 25,000 eggs, trying to have one child or two children seems very doable. But this is where the quality piece comes in. When we're talking about quality of an egg, we're talking about the genetic material in the egg. The egg is contributing 50% of genetic material to a future pregnancy. Sperm is going to contribute the other 50%. The genetic material in the egg and the sperm has to be normal to lead to a successful, healthy pregnancy. As of current technologies, we can't clone eggs, we can't make more eggs, and we certainly can't fix eggs, meaning fixing the genetic material in the eggs. This is another way to think about quality. As the age of the egg goes up, the chance that you're going to make genetically normal embryos, the chance of having genetically normal embryos decreases. At age 30, in that kind of peak fertility time, if somebody is making embryos, this is in the context of IVF, right? Because we're actually seeing the embryos and we can do genetic testing on the embryos. At age 30, 65 to 70% of embryos are going to be normal. That 38-year-old person, the percent of normal embryos is going to be significantly lower. It's going to be 40 to 45%. And then we get to 40, it's about 15 to 25%. So number one, this decline is not linear. The difference between 30 and 35 is very different than 40 and 45. This is why that chance of pregnancy decreases. And this is why the risk of miscarriage goes up. We're going to relate this back to egg freezing, I promise. I do have a point. With egg freezing, what we are essentially doing is taking the eggs out of somebody's body and we are freezing them. The way to think about it is like they're quote unquote frozen in time. meaning that if you take a 30-year-old person's eggs and you freeze them, that person can go on 5 years, 10 years, whatever, and use those 30-year-old quote unquote eggs. And the chance of pregnancy, the chance of miscarriage is going to be that of a 30-year-old. We actually do this not infrequently in the context of fertility. So, for instance, when people pursue donor egg, meaning let's say you have somebody who has a very low egg number, poor egg quality, let's say 45-year-old person, and they use somebody else's eggs from an egg donor, somebody who's 20, 25, the chance of pregnancy, the chance of miscarriage is going to be still that of a 20, 25-year-old person, right? So this is what makes egg freezing so powerful. And again, it drives home that point of how important the age of the egg is. I wanted to bring up AMH, or anti-Müllerian hormone, as well. AMH, it's a blood test. This is a hormone blood test. It's not covered by OHIP, but I believe the lab charges something like $80 to $90 to run this blood test. This is a test that is a predictor of response to ovarian stimulation, meaning this is a test that helps me as a fertility doctor set expectations for patients in terms of how many eggs we might get from an egg retrieval. Again, for egg freezing, for IVF, for whatever. Allows me to tailor the dose of medications that I'm going to use as well. The AMH blood test is super helpful when somebody is considering egg freezing, because this helps me figure out how many eggs I think we might get. This is going to become really important when we talk about predicting success and sort of how we kind of counsel patients around this. AMH is a helpful test that's going to help us predict that quantity part to figure out, okay, do you have more eggs than other women of your age, less eggs than other women of your age? How many eggs might we get from a retrieval? And then what's the success going to be of our cycle? But there's no test for egg quality. So we assume that the eggs are going to be average quality for the age. So again, 32-year-old person, we're going to assume the eggs are probably average quality for that of a 32-year-old person. The one big caveat with AMH, though, is that this does not predict whether somebody can get pregnant naturally or predict the chance of live birth, let's say. AMH sometimes gets misconstrued as like the fertility check, right? As this fertility check test. You're checking your fertility, but it's really not. There is no test that can predict whether somebody can get pregnant or not. It's just one piece of the puzzle that helps me figure out how well fertility treatments may go. But again, it is not intended as a quote unquote fertility check. Let's talk about how egg freezing can work. Generally speaking, there's 3 steps, which we're going to go into. Step 1, stimulate the ovaries, get the eggs to grow. Step 2, get the eggs. So this is the actual egg retrieval procedure. Some people call it an ovum pickup. And then step 3 is actually freeze them. How do we do this? Naturally, in somebody who has a relatively regular menstrual cycle, you're going to you're going to produce about 1 egg per cycle, or about 1 egg per month, 99% of the time. Fertility treatments, egg freezing, IVF, it's a bit of a numbers game, right? So we want more eggs to work with. So we kind of get the ovary to grow more eggs at a given time in a particular cycle by using medications. So these are injection medications. They're kind of almost similar to an EpiPen or similar to insulin pens, where somebody's going to dial up the dose, you hold it, you put the needle into the skin. It's a very, very small needle. They're maybe 5 to 7 millimeters long. They're quite short, and you do the injection. So somebody's going to be doing injection medications for, on average, about 10 to 12 days. During that time, we do close monitoring with blood work and transvaginal ultrasounds, meaning ultrasound probe in vagina. That picture to the right is of an ovary, and you can see those dark circles, those kinds of around the rim of the ovary. Those are the growing follicles. Normally, we'd see only one kind of black circle growing in an ovary in a given month, in a given cycle. Here we can see a whole bunch growing all around the perimeter, and so that's what we want to see. Once the ovaries look nice and ready, and there's lots of nice, beautiful, mature-looking follicles in the ovary, and we think they're going to contain mature eggs, then we plan for our ovum pickup, or the retrieval. Somebody will take a specific medication called a trigger medication. And then usually about 36 hours later, we're planning the retrieval, the procedure. At Markham Fertility Center, we do this under sedation with propofol. This is important because, as you can see, the ultrasound probe goes in the vagina, and there's a needle that goes through the back wall to access the ovaries. Let's just say if I were the patient, I would certainly want to be sedated. I would want some medications on board. And that's exactly what we do for patients. We actually provide deeper sedation because of our anesthesiologist. We are the only clinic in Ontario that has anesthesiologists present at every egg retrieval to be able to give that deeper level of sedation, deeper level of sleep, therefore more comfort. Other clinics use sedation medications, but at different medications that are much milder. So people are more kind of awake and lucid. We're using this needle to access the follicles and to essentially just drain those follicles, get the fluid, and it goes directly to the lab. Procedure time is usually 20, 25 minutes or so. Not necessarily so important to understand this, but just super cool. When we get the eggs, they go directly into the lab and they go into embryo culture. And so they're sitting at 37 degrees Celsius body temperature. In terms of how eggs get frozen, they have this increase in concentration of something called a cryoprotectant, which basically causes them to freeze super quickly. We actually store these frozen eggs and frozen embryos at minus 196 degrees Celsius in liquid nitrogen. So we've got all these great big liquid nitrogen tanks in the clinic. This is another way to think about the egg freezing process, depending on how you prefer your visuals. If we look at the orange line there, that day 1 is supposed to be the first day of period, so first day of full flow. With usually cycle day 2, cycle day 3, you're starting those injection medications. These are versions of FSH and LH. And then we are doing those ultrasounds, that monitoring that you can see with those pictures of those probes. Then we're going to start another medication to prevent the eggs from basically leaving the ovary too quickly until we're doing this egg pickup around cycle day 13 and 14. The key point is that injections are scary for many people, but you're only doing it for about 10 to 12 days. And in terms of actually having to come into the clinic, it's about 5 to 6 ultrasound blood work appointments. And the whole process really is about 2.5 weeks of the more intensive blood work, ultrasounds, and doing stuff. Cost. This is really important to talk about. Elective egg freezing, meaning egg freezing for social reasons, unfortunately not covered by OHIP or the Ontario Fertility Program right now. This is a study done a few years ago. In Canada, the cost of elective egg freezing is about $10,000. On top of that, there are storage fees. If you're storing the eggs year after year, storage fees will vary quite widely clinic to clinic, but we're at about $500 per year. And then there may be subsequent fees later on for if you actually come back to use those eggs to make embryos, etc. It's worth noting, because again, most everyone is Ontario-based, that the Ontario government has introduced, as of 2025, a new tax credit for health-related expenses. Elective egg freezing does count. Those medications do count. So that's another way to help offset costs as well. What are the risks? I think of them as short-term and long-term. Short term, you can develop something called ovarian hyperstimulation syndrome. This is something that can affect anybody using fertility medications. So this could be somebody doing IVF, somebody freezing eggs, somebody freezing embryos. And what happens is that as you are getting a bunch of eggs to grow, multiple eggs to grow, they're all releasing a little bit of estrogen hormone and other hormones. Where now if somebody has 10 to 15 eggs, those hormones levels can get very high. And so people who have mild OHSS, ovarian hyperstimulation syndrome, they may experience symptoms like bloating, discomfort, their ovaries are enlarged. Mild OHSS is quite common, right? 20 to 30% of all IVF patients. But by definition, mild is bloating, discomfort. This is lasting for about a week, week and a half. Severe OHSS, this is the scary one. Severe OHSS, though, it only accounts for about 1% of all IVF patients. In severe OHS, people can get quite ill, sometimes requiring hospital admission, sometimes requiring to be on blood thinners for a week to 2 weeks. This is extremely rare nowadays. With the newer medications, with new protocols, the likelihood of severe OHSS is much lower than it used to be even 10 years ago, but this is a potential risk. There are also risks that come along with the actual procedure, this ovum pickup or this egg retrieval. I mean, we're taking a needle and we're poking in through the vagina and we're poking the ovary. Bleeding can happen, infections can happen inside the abdomen. There's stuff around the ovaries, right? So blood vessels, the bowel, bladder. So theoretically, there's a risk of injury. There's also sedation related risk. Anytime you have any type of sedation, anytime you're put to sleep, there's risk with that. Can be something like risk of damaging teeth if they need to put something in the airway, risk of causing some issues with the jaw as well if they have to sort of push on things to help you breathe. But the risk is quite small, and we're doing the procedure under ultrasound guidance. We can see where the bowel is, where the bladder is, where the blood vessels are, and so that allows us to avoid those dangerous things. Some patients will certainly have more difficult, more complicated egg retrievals than other patients. So the risk really does vary with the patient, and so it's something to discuss specifically with your physician. Another risk is something called ovarian torsion. If we go back here for a sec to this picture, I really like this picture because it's very realistic. The ovaries, when they're filled with lots of big follicles, get really big and really heavy. And this is why somebody is going to feel bloated and full, right? It's good for the fertility doctor because it brings those ovaries really close to the vagina. So they're super easy to access at retrieval. An easy retrieval is a safer retrieval. And there's lots of eggs, which is always nice. But what can happen when they get really big and heavy is you can see they are sort of on this very thin stalk that connects it to the uterus. And so what can happen sometimes is that the ovary can actually twist on this stalk, and the stalk contains the blood vessel. So if you think of a garden hose, right, that has water flowing through it, what happens if you twist it? It kinks, right? And there's no more flow. So ovarian torsion is a condition where the ovary twists and the blood supply to the ovary can get cut off. This is a surgical emergency. The vast majority of time, somebody is going to have really significant one-sided abdominal pain, usually nausea, vomiting along with it. It's something where something is up that you need to go to the emerge. If it happens, does require surgery where the gynecologist, the surgeon will actually physically detort or untwist the ovary. The risk overall of ovarian torsion is quite low. But for people who have big ovaries, we do tell them to avoid things where they're bouncing, running, yoga, or sort of, poses where you're kind of upside down. Anything that could kind of cause that twisting, right, is something to be avoided around the time when the ovaries are big. But again, it's about a week and a half time frame for that. There are long-term risks to egg freezing as well. These are a bit more abstract. This is what I mean. If somebody freezes their eggs, then that's probably because they're delaying childbearing. So there are risks that come with delaying childbearing, right? Being older and having children. And so that's an important point to mention. As people are older, the risk of having high blood pressure in pregnancy goes up, gestational diabetes goes up, risk of needing a C-section goes up. So obstetrical risks increase. Financial loss. This is also really important to consider because egg freezing is not a guarantee. Very often you talk about egg freezing as a quote unquote insurance policy. It's not an insurance policy, okay? You freeze your eggs today, you come back in 5 years, they might thaw okay, they might not. They might lead to healthy embryos, they might not. We don't know. None of us have a crystal ball. The other thing is that you don't actually know if you're going to come back and use those eggs ever. I mean, maybe you end up conceiving naturally and having kids and you never use those frozen eggs. Who knows, right? So there's that potential financial loss of spending money that maybe doesn't get you the goal at the end. This is a bit kind of reaching, but again, when we have frozen eggs, there are certain things that we have to do with the frozen eggs to be able to use them to make embryos. One of those things includes fertilizing them with sperm with a specific technique called ICSI. Some patients, some people really feel strongly against that, so it's also worth mentioning. What is really important, though, is that if somebody freezes their eggs, there's absolutely no evidence that this leads to earlier menopause or a decreased egg reserve or that it affects natural future fertility in any way. That's really important. So if you freeze eggs today, you're not affecting fertility down the road. Success rates. If I freeze my eggs now, what are the chances I'm going to have a baby, right? Because that's really the important question. Because when somebody is considering freezing eggs, not freezing eggs, making this financial investment, you want to know at the end of the day, what is the chance that this is going to lead to an actual live birth, like an actual baby in my arms? Many researchers have put together these statistical models using data to help us give numbers, to help us make these estimates. These models will often use the age of the egg, right? Again, driving home how important that is, and the number of eggs that we get. As I said, we use the AMH blood test to help us predict how many eggs we might get from a retrieval. So if I know what somebody's AMH is, I can kind of estimate the number of eggs I think we're going to get. I know their age. I can give a rough estimate in terms of what I think the chance of a pregnancy down the line is. This has so many lines and so many colors. What I want to illustrate is age matters and the number of eggs matters, right? More eggs is going to lead to higher pregnancy rates, and younger eggs is going to lead to better pregnancy rates. And the difference is really quite stark, right? Between somebody who is under 35 and somebody at 40. This is another way to kind of look at the same question. It's a website where you can put in somebody's age when they're freezing eggs and put in the number of mature eggs that you might expect. And it tells you, it spits out the chance of having at least one live birth, having at least two live births from those eggs. So 2 kids from those frozen eggs. But again, age and the number of mature eggs is basically showing up in every single one of these potential calculators and predictors, right? This is what I use to help counsel patients when we're talking about, okay, is this worth doing or is this not? It's important to note, though, at the end of the day, it's never 100%, right? Like there's never any guarantee. It's very important to really think through this discussion, this concept, and to think about whether it's worthwhile. Switching gears a little bit, getting into embryo freezing. I want to be super clear in terms of what an egg is and what an embryo is. An egg is not fertilized, so there is no sperm involved. An egg is one cell. So when somebody freezes their eggs, this is somebody who has ovaries, who has eggs, who's coming in, and they're the only person involved, essentially, right? Where it's just those eggs, those singular cell eggs. An embryo is egg plus sperm plus a whole bunch of rounds of cell division. So an embryo is a ball of several hundred cells typically. The other important thing is the sperm in an embryo is locked in. You can't change the sperm. You can't go in there, take out sperm and add in different sperm. This is really important because if somebody is freezing eggs, they're your eggs. No one else is involved. If you're freezing embryos, one person with eggs, one person with sperm, these two people are now locked in together, meaning that, let's say there is a heterosexual couple, they come to see me, they freeze their embryos. Her eggs, his sperm would make the embryos. A couple years down the road, things don't go well for them. They end up divorcing, separating, whatever. If she wants to use the embryos to have a child now, he has to provide written consent. He has to consent to the frozen embryo transfer and vice versa. Meaning if he wants to use the embryos with somebody else or a surrogate or whatever, she is signing the frozen embryo transfer consents as well. So now these two people are essentially locked together. This embryo is set, right? This is really important because if you're considering embryo freezing versus egg freezing, you really need to have a solid look at, let's say, the relationship that you're in and make sure that, this is the person that you for sure want to have children with, right? When I'm talking to patients about embryo freezing versus egg freezing, we also have a heart to heart about the relationship and how things are going as well. I get all up into the nitty gritty of everything because I think this is really, really important because we have definitely had patients who do IVF with their current partner, make embryos, and then, relationships don't work out for a million reasons. And then these embryos are kind of in limbo. Maybe she wants to use them, he doesn't want to let her, and there's nothing we can do. The other thing about eggs to embryo, this rate of attrition, this concept. In the world of IVF, there are many terms that are used to describe this. The funnel, the rate of attrition, whatever. This idea is you're going to get a bunch of follicles on ultrasound, and they're going to yield some eggs. Not every egg is going to be mature, meaning usable. Not every egg is going to fertilize with that sperm. not every egg is going to grow to the embryo stage, the blastocyst stage. And not every blastocyst, meaning this embryo, this ball of hundreds of cells, is going to lead to a pregnancy. So there's always this funnel. There's always this rate of attrition that occurs in the world of embryos and IVF. When somebody freezes eggs, they're stopping essentially at this red dashed line. And everything that's going to happen after that is unknown. We make educated guesses. We use these great fancy prediction models to give us the number to help us figure out the chance of that baby at the end. But at the end of the day, nobody has a crystal ball. So there's so much unknown when you freeze eggs. When you freeze embryos, you've now taken yourself all the way down to the bottom of the funnel. And so when you are freezing embryos, you've got a lot more information. The way that I explain it, and I realize that this analogy is very apropos today. An embryo has essentially made it past many more hurdles to get to this quote unquote freezable stage. With frozen embryos, there's more confidence, there's more certainty, there's more clarity about the pregnancy rate, about the chance of an actual pregnancy, chance of a baby at the end of the day. But sperm and the sperm provider, you're locked in. When you freeze embryos as well, there is a higher cost, but that cost, it's roughly equivalent to freezing eggs and then taking the eggs, thawing them, and fertilizing them and making embryos. So it's kind of like you pay everything up front, or you pay a little bit, or the vast majority actually, like 85% now, and then 15% later on if you come back and use them. This is the really important difference between egg versus embryo. And I think that this is a very important individualized, personalized decision that you have to think about. At the end of the day, though, if you're sure about where the sperm is coming from, it's probably better to freeze embryos than eggs, only if you're super sure about the sperm, right? Because there's a lot more certainty that comes from that. But if there's any doubt, question, whatever about the sperm provider, about where the sperm's coming from, then for sure freezing eggs makes sense. Again, this is a nuanced discussion and should be kind of had one-on-one with a fertility care provider just to give some thought or some context in terms of the egg versus embryo. To be honest, it is a debate nowadays. I think really when egg freezing first came out, it was thought to be this like magical fix to aging, right? That everyone's just going to freeze their eggs and then people will get pregnant later on and it's going to be great. But then people started to realize like, well, you might be sitting on these frozen eggs for 5 years, 10 years, thinking that you've got this great backup plan. But now sometimes we're faced with patients who come back to thaw their eggs to use them and they don't thaw well and you lose half of them. Or they thaw, but then you don't actually get good embryos. The challenge, the emotional sort of dealing with that is extremely difficult, right? So that is why I think we're now sort of moving to a much more nuanced discussion about eggs versus embryos freezing, and about being more realistic about egg freezing as those expectations as what can happen down the line. Changing gears again, sperm freezing. Sperm is a very, very different scenario than eggs. The physiology is super different. Sperm is produced continuously through someone's lifespan, unlike eggs. So every 3 months, there's a whole new cohort of sperm in the testicles. There is such a thing as advanced paternal age. Definitions will vary, but generally over age 45, in someone who has sperm, we're going to start seeing declining sperm quality. But this sort of very specific graph, this very clear line that we can draw with eggs, it's not the case with sperm at all. And again, there are countless examples in pop culture, celebrities, whatever, where we see people with sperm going on and having kids through a much wider, much larger kind of time span through their lifespan than, for instance, people with eggs. This is just because sperm and eggs are very, very different. Why would somebody consider sperm freezing? Why then preserve fertility for sperm if age doesn't really matter so much? Advancing age, much less of a concern when it comes to sperm, until you're kind of getting to maybe like age over 45. But there are other things. Travel and geography is probably the most common reason I would say why people were going to freeze sperm. Let's say there's a situation where There's a heterosexual couple, and she is doing inseminations or she's doing IVF. She's pursuing some kind of fertility treatments. And the partner is not able to be present or to be available for those times when the sperm is needed. Like on the day of the IUI, we need the sperm sample. On the day of the egg retrieval, we need a sperm sample. Couples who live far apart, couples who live in different countries. The partner with eggs can continue fertility treatments, inseminations, IVF, whatever, because that partner with sperm can freeze the sperm and we can then thaw it when we actually need it. The partner sperm does not need to necessarily be physically available if we have frozen sperm that we can use. It's very helpful when we're accommodating scheduling and geography for couples. Sperm freezing, there are certain sports associated risks to consider as well. In sports where there's a high risk of groin injury, that can certainly affect the quality of the sperm. So contact sports we're talking about here. Cycling for sure has a somewhat of a negative reputation, I think, when it comes to sperm and sperm quality. And the reason is it's absolutely true. So the pressure from the bike seat can negatively affect the sperm and can cause kind of micro trauma in the testicles, especially if we're spending many hours on the bike, not like me recreationally going out once on a weekend, maybe sometimes. And then the heat. Heat is extremely important when it comes to the testicles and the scrotum. Let's face it, right? If somebody were really designing the human body, having the testicle, having the scrotum outside of the body, probably not the best design. The reason that they are outside is because sperm like a little bit cooler than body temperature. They want to be outside as a way to kind of be a bit cooler to cool down. So the pressure from that bike seat increases heat. Also, seated sports like Formula One drivers, for instance, where they're seated for long periods of time, and occupational stuff like taxi drivers, line cooks. So people who are standing next to a hot stove all day, we're seeing effect of the heat on sperm. Swimming is another one, but that's really going to be dependent on the temperature of the water and risk of increasing scrotal temperature. There's also some thought that very high volume endurance training, a marathon, ultramarathon, a triathlon can disrupt hormone levels, which can also potentially negatively impact the quality of the sperm. I'm sure this is not relevant to this group. However, it is worth noting that many performance-enhancing medications, many of which are not legal, likely do have negative effects on sperm that can be really, really long-lasting. Certainly, I've had many patients who have gone on testosterone, who've gone on anabolic steroids in the past, and they've stopped them, but now they have infertility and they actually have literally 000 sperm. And it can take a very long time for that sperm to come back, if it does come back. How does sperm freezing work? This process is much simpler than egg freezing. One appointment, the sample can be produced via masturbation, either at home or in a fertility clinic, depending geographically how far home is from the clinic. The lab, the andrology lab, they get the sperm sample, they do a wash, taking out the dead sperm, the not moving sperm, all the other stuff that is in semen. And then they freeze the sample in straws. They will actually divvy it up amongst, we call it straws. These are sort of like little storage vials, essentially, and the sample is frozen. Then there's another appointment with a physician to review the sperm sample that was provided at that time, and then a post-thaw analysis. So they'll divide the sperm up into however many little vials, and one of them they will freeze and then thaw shortly thereafter to give us an idea of what the sperm looks like when it gets thawed out as well. Because generally speaking, about half of the sperm does not survive the freezing and thawing. But for a normal semen analysis, there's many millions of sperm present. So even if you lose half, there's still lots of sperm present. This is something that's not covered under OHIP. It's about $400 per sample. Some final thoughts here. Elective egg freezing can certainly provide another avenue to help people build the family of their dreams. But success rates are going to vary based on age and egg reserve. Embryo freeze, you're locked in with the sperm, but you can have more confidence with pregnancy rates. Sperm freeze, again, not as common, but may be helpful in certain specific scenarios. All right. Any questions, comments, concerns?
Okay, so the question was, can you touch on the effect of birth control or IUDs on fertility?
Yes, absolutely. Basically, birth control pill, IUD, no long-lasting, long-term effects on fertility. Full stop. With an IUD, there's two types of IUDs. There's hormonal IUDs and the non-hormonal IUDs. Both of them, we leave them in the uterus all the time if patients are actually undergoing egg freezing cycles, for instance, and they don't affect the egg quality, they don't affect the cycle outcomes. They don't necessarily need to come out. If somebody is trying to get pregnant, let's say you take the IUD out, that period, the menstrual cycle and fertility is going to come back. Usually takes 2 to 3 months, especially depends on how long the IUD has been in place. But then you go back to what your cycles were like prior to the IUD. What I mean is that if your cycles were regular before the IUD, then they'll go back to regular. If your cycles were irregular prior to the IUD, they're still going to stay irregular. Birth control pill, again, as soon as you stop it, you can potentially get pregnant, which is why even missing one pill, there's chance of pregnancy. So there's no long-term effects on fertility, either positive or negative for either.
I want to thank you so much, Dr. Wise and the Markham Fertility Center team. This has been such a wonderful overview and speaking on behalf of everyone, but I think you shared a lot of really insightful information to keep us thinking. We want to thank you for your commitment too, for sharing such important knowledge with our athletes and sport community. Thank you. And we really appreciate everyone taking the time tonight, especially on a sunny evening such as this one, to make it out and see you in a couple weeks.
I thought about presenting outside, but I was like, that's probably too much.